Good evening and welcome to our wonderful listeners. We're so happy you joined us today. It's so good to be back with you. It's fall and we're here, and it's the great month of November. And before we get started with our podcast today, we're going to have everyone share with us what their plans are for Thanksgiving. So, why don't we start with you, Laura?
So I'm going to be doing the same thing I've done every year, and that is we're going camping. And so our tradition is I host my whole family the Saturday before Thanksgiving. So I'll be doing that. And Sunday, we'll be hitching up the trailer and we'll be driving up to Central Florida where we have the whole week of Thanksgiving festivities. And we're really, really grateful that we get to celebrate it with our extended family, which is our church family. And just have Thanksgiving in the woods and just be so grateful for being able to do that in Florida in November, where some other places are pretty darn cold by this time, and just run around in the outdoors and enjoy.
Wonderful. What about you, Vin?
I definitely will not be running around in the outdoors.
That would be fun to see.
Yeah, tell me about it. So I'm probably going to do exactly what I do every year. My family just get together with family. It has been a tradition since my youngest got married. Basically, just sit and dine with family. That's it.
That's nice.
That's it.
What about you, Raquel? Our special guest is Raquel, and she's going to share with us what she's going to be doing for Thanksgiving.
So just like the two young ladies said, I will also be doing the same thing I do every year, which is going over to my sister's house for Thanksgiving. She hosts every year. We all do bring a dish. Mm-hmm. I'm usually in charge of the sweet potatoes.
Oh, nice.
So it'll be me, my husband, my two children, her son, husband, my 90-year-old grandma, and more than likely my uncle will be coming down from Brooklyn with his daughter. So we're praying for that this year. That'll be our first.
Nice.
So looking forward to that.
And you, Angie?
My turn. Yeah, for the past few years, we've taken up the fried turkey craze. And so we also explore the outdoors, but it's more by the pool. And we all get in our, T-shirts and shorts. And my brother-in-law takes care of the turkeys and usually tries a different marinade each year. So who knows what he will try this year. But I think I'm going to put it in order for Raquel sweet potatoes. And then maybe that's what I'll take over to my sister's house.
Let me know.
You got it.
Nice, nice. So we're all excited about Thanksgiving. And for our family, it's when our two families get together. My firstborn is married. His wife's family comes over and we join with them at the children's house and we celebrate Thanksgiving together. It's really a bouquet of food, if I may use that word, from many cultures, local and otherwise. So that's what we'll be doing for Thanksgiving. So I guess we want to wish you all a very happy Thanksgiving. And let's get to our podcast for today. So today we have a very special guest with us, and we're going to be highlighting Black maternal health. Did I say that right? Yes, so we're going to be looking at that. But before we do that, I want to introduce you to Raquel, who will share a little bit about herself. Just tell us what she does and why this means so much to her, and then we're going to get into the topic. So Raquel? Share with us.
Okay, so again, my name is Raquel Stanley. I was born in San Jose, Costa Rica, but I reside here in Miami, Florida. I am the mother to two beautiful young children, very wonderful husband who's very patient, but very supportive of all my passions and endeavors. I got my bachelor's in science of nursing from Baylor University and my MBA from Nova Southeastern University. And I immediately started working at Baptist Hospital of Miami 21 years ago. And I am blessed today to be the nurse manager of the unit where I started 21 years ago. So I am now the nurse manager of labor and delivery. And I had heard about the whole Black maternal health. You hear it. But it was a lecture series that I went to where it specifically spoke about the statistics in Florida that did me in. I felt like this is happening in my backyard. And I'm on a unit where it may happen or possibly does happen. So I have power to maybe have some influence or plant a seed or something. So I came from that lecture just ready to go. And we hosted the first Black Maternal Health Week booth at Baptist. It was the first ever for the organization. I also went to, I forgot the name of the church last weekend, but we also had a booth for Black maternal health. And I've worked on a PowerPoint presentation for it, and just different things to get it out there. I also sent out a global email to everybody at Baptist Hospital of Miami called Help Me Save a Life, where I included a PDF with basically all the warning signs, maternal warning signs, for them to share with either their wives, their sisters, their friends, or to pass it on. Because what we don't realize, and what I learned, is that yes, there's women who die in pregnancy, but it also reaches up to a year after having had a baby. A lot of people didn't know that. So that has helped. A lot of people email me with different things like, oh my God, I saw this podcast, or I saw this flyer, I'm sending it to you because of that email that I posted to the whole hospital. So, any little bit I can do, any seed I can plant.
So you mentioned that you started in that unit and you're now the manager. So would you say your passion in nursing has always been labor and delivery, maternal
I
health?
think my passion has always been just in women's health.
Women's health.
In general. Obviously, I was blessed to land there, but I think women's health just in general. I just am baffled by sometimes the lack of education, even in the most, not necessarily poor environments. Sometimes educated people are just not informed on the right things. So,
Did you discover that you learned more about I would say with your timeline that this is true? They didn't teach you this necessarily in school? That's, it's encouraging to me, who I'll call myself ignorant in a lot of things medical. But then, we elevate a fraction of the conversation.
Yes.
So where did your most of your aha happen?
Miami-Dade County is the second county with the highest mortality rate in Florida.
Wow.
I live here. It's
With
my
this
backyard.
population,
With this particular population.
Okay.
But nonetheless, in the country, the United States, has a 60% mortality rate of women, not necessarily Black, but all pregnancy-related complications or death. 60% of the United States out of other highly, influential and economically savvy countries.
Yeah.
You would think that we have it together, and we don't, and it's only getting worse. So I think that was my...
Does that have to do with prenatal care? Does it have what leads to that type of statistic?
Okay, so there's various things. You have the variation in healthcare. You have some hospitals that provide great care, and then you have hospitals that have limited resources. You also have patients who don't have access to good quality care. You have, unfortunately, structural racism. You have implicit bias, which are just thoughts, subconscious thoughts that we have that we don't even realize we have about certain genders, races, groups of people that dictate your behavior, or your actions or care towards patients.
Right.
Those are some of the biggest factors on why it's going on, and just lack of resources, lack of education, accessibility. Those are some of the biggest resources or issues for why.
So would you say, you did say that within a year, still people die after giving birth.
Yes.
So is one of the factors because they do not do follow-up appointments?
Exactly. So the recommendation now, which is something that we're instituting at our institution, is that all pregnant women, especially those that have had high blood pressure, should see their doctor within 3 weeks of having a baby.
Okay.
It's not happening. So you find a lot, especially, again, the Black population, a lot of them are not following up. A lot of them have the diabetes. A lot of them have the high blood pressure. A lot of them have those, cardiac issues that are not followed up with. And then by the time they do say something, it's too late sometimes. And sometimes some of the warning signs, I'm too tired, blurred vision, I have a fever, or, oh no, but it's okay, go get some rest, you'll be fine. We don't have money for a copay, don't do that. Just take some Tylenol, you'll be okay, So it's a lot of those things, a lot of those insidious symptoms that sometimes we just think are related to just having a baby, and that's not always the case.
Right.
Let's go back to before. What are some of those stereotypes that set our women up for the trauma that comes prenatally, that leads into the hypertension and the proteinuria and all the other things that lead to the preeclampsia and all of that? what are we doing or not doing to help our women or to educate women so they know when to respond? Is it that we should choose a certain type of OB who responds to our women better? That's one issue. And then is it that we need to educate our women to know these are the signs, which I would think is being done prenatally? So talk about that a little bit.
Honestly, I think it's a 50-50. I think that the patient has an onus, and I think the physician does too. I don't want to say that them going to a Black physician is the answer, because I can tell you Black physicians have implicit bias as well. Some of the things, for example, that are still out there from many years ago, Black women have thick skin. They have less nerve endings. They complain a lot. They're not going to keep their appointments. It's those things that have come from a long time ago. So they have in their mind, oh, she didn't come for her appointment again today. She doesn't care about her baby. She doesn't care. Not thinking maybe she didn't have money for the bus. Maybe she didn't have a ride. Maybe she doesn't have accessibility or the resources for a Lyft or an Uber. It's not that she doesn't want to be there. She just can't get there. Their assumption is the Black person is just irresponsible. They don't want to take care of themselves. I think you have to look at literacy. Sometimes people don't know how to read. I can give out as many pamphlets as I want, but if they don't know how to read, how do you? So I think it starts from physicians and healthcare providers, not just physicians, healthcare providers, period, physicians, nurses, administrators learning, again, that implicit bias and the history and where it comes from, as well as the patients also taking some onus, like, what do I need to know? Sometimes it's not reading. Sometimes you just need posters. It's like when McDonald's went from reading to just pictures of hamburgers, like sometimes you just need pictures for them to see, So
It seems also, and I could be wrong, that we need to catch up in our research.
Yes.
Because when I'm thinking about populations for hundreds of years now that didn't receive care for whatever reason they didn't receive care, then that didn't give us the opportunity to research on those populations.
Yes.
And so now we need to elevate that conversation.
Absolutely. And again, going back to where it starts from, because there were a time many years ago where there was a hospital for the Black and a hospital for the white, and the hospitals for the Black people didn't have the best quality care. We're not treated with the best respect or anything. So it's just something that has kind of slowly come into now, and we just need to.
Do you think that there is a concept of having babies being so natural for women, and an era when nobody touched the woman because it was a sacred place, that there is that thought that, oh, I'm pregnant, I don't have to be going to this and that, nobody has to touch me, I don't need medical help. So there is that lack of literacy about what can happen?
Absolutely. And it's funny that you say that, because at the wellness fair and expo that we went to last weekend, there was a young lady that came to the booth and she was 8 weeks pregnant. And she just needed everything. I'm like, I wanted to bring her home and talk to her about everything, because she was looking at this poster board that we had, and she's like, really, you can bleed? Like, so you can have like high blood pressure when you're pregnant? You can have diabetes when you're pregnant? And the baby comes out and the baby can be, I was really taken aback by that. I'm like, wow, we have work to do. Because she's pregnant, excited and happy and go lucky, and thought that this was just going to be a smooth, but I realized why. So, gave her the flyers, really told her, make sure you meet with your doctor after you have your baby. If you have any of these issues, just, there is that,
So-
exactly what you're saying. You just get pregnant, that's just what it is. I don't have to go to a doctor. We told her, no, you have to. You have to. And even more so at the end,
So Raquel, is this happening more with single women, or it happens with single and married women?
Single and married. Wow. All Black women are at risk.
So where but as far as does the husband accompany the wife to the appointments? Do you find that it's happening?
For the population that we see at Baptist Hospital, for the most part, yes. The population we have does have that significant other.
Okay.
It does make a difference. I know that we make sure to educate them, especially on the postpartum depression. We make sure to let them know your wife is, at a higher risk for being a Black female for depression, and she may not say it to you. So if she's any different from who she is today, 2, 3, 4 weeks from today, make sure you bring it up to her physician because that's very important.
Now, why is she at higher risk?
Just because women, Black women, a lot of Black women don't feel comfortable stating that they're not well mentally, or that they
Okay.
feel like harming their baby, or that they feel like harming themselves.
Got it.
And again, that's something that comes from past.
Yeah.
A stigma not to, you don't, you know, say that you have issues.
Yeah.
You got to be a
So-
strong Black woman.
Yes, yes. So we educate, if the significant other's not there, like if the sister of the patient's there, the mother of the patient, we
Right.
tell them the same thing. If she's not who she is now, and we tell her, if you don't feel right, you feel like you want to harm yourself or your baby, the thoughts of putting a pillow even for a second, you get help.
Okay. So that's regardless of socioeconomic status.
There's a higher incidence of postpartum depression in Black women, but period, in women,
Okay.
there's a rise in postpartum depression.
Wow.
There is.
They're in the media. Beyonce,
Yes,
she had an issue.
yes.
Venus?
Serena Venus.
Serena.
Yes.
The other one.
Serena Williams.
Serena Williams, she also had a major
Yes.
issue. And these are affluent women
Yes.
with money. They could
Yes.
have anything they want. I
Alison
would
Felix.
assume, yes.
And then the one
that
who just passed
was-
away, Tori Bowie.
Okay, so these celebrities,
Mm-hmm.
they're speaking out, but I
Yes.
think their voices are not being heard enough. When I think back to 1992 and HIV,
Okay.
the minute Magic had it, HIV changed.
Yes. Yes.
And HIV has changed forever because of
Of
Magic.
that. Yes.
So right now we are poised to have Beyonce
Yes.
and Serena and Felix
Alison.
be the spokesperson
Absolutely.
to make this loud
Yes.
and make it. I still think, as you said, the female has this need to know that it's natural but not all natural. We need help.
Yes. Yes.
And I think if those ladies could be on the platform and we could really get their voice, first of all, I think a lot of other women would join in. We'll begin to hear other stories. How can we mobilize that? Because these are rich women, powerful women, and we know that it's across the board. Because if they're having it, we know the ones who are less fortunate without the resources are going through it. We don't
Yes.
hear of those deaths.
No.
It just happens quietly.
Yes.
So what can we do in the health world? You are a leader in that world.
Yeah.
And how can we mobilize the resources, humanly speaking and otherwise, to make this loud, to change?
Well, I can tell you right now, specifically on our unit at Baptist Hospital of Miami, we are working with Florida Perinatal Quality Council, which has put out basically a plan for all hospitals by a certain time to have a program that caters to the identification of Black maternal health issues and your risks. We're also working on social determinants of health and identifying those things ahead of time. For example, is she homeless? Is she in a domestic violence? Resources, how close is she to a pharmacy? Her school level, just all of those things to kind of identify that before. We're actually on that journey now.
Okay.
To identify. It's going to be hard because some may not answer truthfully, but it's worth the try, right?
Yes.
Absolutely.
So we are on that venture with FPQC and the social determinants of health. We're excited about it. We're training the staff on it. We're doing implicit bias tests so that they understand, you know what, we all have implicit biases, and the sooner we identify them and work through them, we'll be better providers to our patients. Our next layer will be the physicians, you know. We have physician champions that have told us they want to join us on this journey. So that's very good. One of them happens to be Black, and ironically, the other two are Hispanic, and they're on it. And that's good. That's
Yes,
good because it just shows that
absolutely.
diversity, you know? Because I don't think that it has to be Black OBs. I don't think that's always the
Right.
case.
No.
I think it just has to be somebody who cares, who's passionate about it, and open to the fact that we have a problem. and that we can do something about it, you know? I'm hoping that from there, it'll kind of grow. I do believe policymakers are important. Hospital administrators are important, because basically the more backing and support you have, the more momentum.
Right, right.
Yeah, I think
have,
another piece of that is to the question Angie asked, which is academia, right? So start educating
Yes.
from then
Yes.
on
Yes.
this, right?
Yes.
Because you're trying now to kind of address it
Absolutely.
when the doctors are already doctors,
Yes.
right?
Yes. Yes.
So
And it goes back to her asking me if I had any training in school. In
Yeah.
nursing school, it's not, at least when I went, it was not there.
Right.
And when I did some research, a lot of the physicians say there's no part of my training that talks about these things, you know? So yes, it's uncomfortable conversation, but it's what's going to cause a change. So
It's very minimally talked about
Yes.
until you specialize. That's the problem.
yes.
Because it goes into specialization and it goes into cultural and sociological issues. And if you're not, if the school is not proficient with that,
Yes.
they're not going to pay attention.
Yes.
So it comes with much later socialization because even in the master's program in nursing, if you're on a FNP track and not on a woman's health track,
You're
you're
not
not
going
going to
to.
pay
Yes.
attention.
Yes.
It's
Yes.
all cardiovascular.
Yes.
in the
Yes.
regular track for women's health. But then if you go into the maternal,
Then
then,
they might.
you'll start focusing a little bit on that. And then the implicit bias messes with that.
Okay. And statistically, does it show, is it more younger women, like between 18 to 25 versus maybe 20 to 40? Or what are the statistics?
I don't know. I only know just the race. I don't really know by number, but I know that 4% of Black women
Yeah.
have a higher chance of dying in pregnancy or after pregnancy than most white women.
And
I
I
don't
think
know
to
about
address
age,
what you
you know.
said, Venoria, women who are over 35 typically will get a little bit more attention because everybody expects it to be complicated.
Yes.
Or there may be
They're
some
considered
kind
advanced
of-
maternal age, so they do get the
Exactly.
extra
You're
visits
old.
and so forth. But again, depending on the quality of care of where it's,
Right,
because at my
right.
hospital, yes, I could say that, but I don't know if in another
Right.
hospital they would do the same.
Right, exactly. So what I'd like you to do before we wrap up, Raquel, is kind of look at the audience and give them some signs to look for. What are the things women should look for when they're pregnant at the beginning that would guide them down the right path to getting proper health? What are the things they should be aware? Risk factors, predisposing factors.
Some of the risk factors, of course, if you're diabetic or have a history of diabetes, hypertension or high blood pressure, cholesterol issues. The simple fact, if you're Black, African American, you're at a higher risk, basically. Be an advocate for yourself. If something feels off, don't be afraid to ask for help. And if your provider, your doctor is ignoring you, you go to the closest emergency room and you say, you know what? I'm Black. I have a 4% chance, higher chance of dying in childbirth or up to 1 year later. So I really want somebody to take care of me because I don't feel normal. I don't feel right. Some of the things, because I don't want to miss any, that you can look out for, again, while pregnant or within the first year after having had a baby. Headache that won't go away or gets worse over time. Dizziness or fainting. Changes in your vision. Fever of 100.4 or higher. Extreme swelling of hands or face. Thoughts of harming yourself or your baby. Trouble breathing. Chest pain or fast breathing heart. Severe nausea and throwing up. Severe belly pain that doesn't go away. Baby's movements stopping, like your baby's not moving as much as it usually does, or slowing during your pregnancy. Severe swelling of redness or pain of your leg or arm. Vaginal bleeding, heavy, overwhelming or fluid leaking, bleeding or discharge, tiredness after pregnancy. Those are things that you don't want to ignore. I know a lot of us will tell, oh no, but that's part of pregnancy, it's normal. But if it's ongoing and you feel inside that it's not, then it's not right. It's not normal. It should not affect your quality of life. You should still be able to take care of your baby with positivity, and hopeful and expectant. And if you don't feel that way, then something could be off. So I highly suggest you either reach out to your provider or just go to your nearest emergency room and tell them.
I would just like to say no questions, but thank you. Thank you, because I've learned a lot from what you shared with us. And thank you to the Baptist Health System, because they helped me bring my 2 beautiful babies to this world. So I'm very thankful.
And with that, our beloved viewers, we're going to bring this podcast to a close. And we trust that you have gathered a lot of valuable information today to protect you. If you're pregnant, we encourage you to seek good obstetricians, get good advice. If you feel uncomfortable, seek help somewhere else. Miss Raquel Stanley, we thank you so much, Raquel, for sharing with us. And we hope that you've gathered some of the risk factors, some of the symptoms you could be having that you need to talk to someone about. Please don't hesitate. Our job here on the podcast is to help you to be educated and to take good care of yourself. So until next time, have a wonderful Thanksgiving, and we'll see you soon. Good night.